Tobacco cessation in teens. Evaluating the Not on Tobacco program. 4,000 youths take up smoking every day. Over 2.5% of 8th graders, almost 5% of 10th graders, and 10.5% of 12th graders smoked in the past month, according to a 2015 national survey. If trends continue, 5.6 million minors who are alive today will eventually die from smoking-related disease. The American Lung Association's Not on Tobacco, or NOT program, uses trained community facilitators and peer group discussions to encourage youths ages 12 to 19 to quit smoking or minimally reduce cigarette amounts. The Not on Tobacco program started as a collaboration between West Virginia University for Public Health Research and Training, West Virginia State Health and Education Departments, the Coalition for Tobacco-Free West Virginia, and the American Lung Association, with the express goal of creating a plan to reduce teen smoking. The NOT program provides American Lung Association trained facilitators in a classroom setting to youth ages 12 to 19. The students attend 10 weekly sessions, each lasting approximately 50 minutes, surrounded by peers of the same age and of the same gender. Classes deliver tobacco-relevant information in journals, that is, in teen-friendly language, along with nutrition and physical activities. Smoking cessation information and tactics, including initial quitting, stress management, effects of smoking, healthy living, along with relapse information, is provided in the facilitated sessions. Program flexibility. A program that can differentiate from rural and suburban, able to adapt to the age and education of the youths, prepare for areas where attitudes about tobacco may be liberal due to geography and environment, example, in tobacco-growing areas, while taking into account challenging factors like smoking parents, is important in addressing social determinants specific to health and smoking cessation. The NOT program provides smoking cessation materials, reinforcement, and activities that allows the facilitator flexibility, adapting to the youth sitting in the class, along with the circumstances that may be unique to the surrounding areas, such as cultural characteristics, social marginalization, and lack of community empowerment. Not on Tobacco program developers and facilitators want to provide information to smoking teens on what using tobacco costs their health and well-being, but also provide them with the means to feel empowered that they can quit, or at minimum reduce the amount of cigarettes smoked. Although getting the information to rural areas and the underserved populations was the original goal, the adaptability of the program made it easily transferable to other locations, and since its inception in 1997, the NOT program has spread to 48 states. The program's ability to be utilized in numerous types of environments was due to the accomplishment of another program goal to create a smoking cessation curriculum that could be duplicated and used in just about any type of environment. What are limitations to the Not on Tobacco program? For example, are facilitators easy to come by? Does the program do enough to cover various types of tobacco? And is there enough support from the local school environment that hold the smoking cessation program? The NOT program focuses on youth smoking ages 12 to 19. Program viability needs to be evaluated through intervention methods along with acceptability of the program, feasibility, relevance, adaptability, and associated costs. Is the program relatable to the smoking teens? The NOT program addresses audience relatability through facilitator recruitment and in creating small homogeneous classrooms. Facilitators are recruited and trained under the American Lung Association from the communities they are serving. Classes are gender specific, including the facilitator. Language is used that is recognizable by the teens it's meant to address. Taking into account the financial restraints of the participants, classes are free. Can the program be replicated and adapted to various types of environments? The program facilitators are encouraged to adapt the program to meet the needs of the participants, including the possibility of adding 4 booster modules. Is there a way to gauge or determine the program's success? Studies along with quantitative measures can be used to determine the success of the NOT program in a given community. For example, after NOT program participants answered a survey about their smoking cessation for the Appalachian Teen Smokers Not on Tobacco 15 months later study, carbon monoxide readings were collected and they were matched to the survey answers provided by the same study participants. The program's success could be judged in both qualitative and quantitative manners. Creating a successful smoking cessation program requires an understanding of the social determinants or disparities that may have encouraged smoking to start and awareness of potential remedies for the challenges in smoking cessation. The Not on Tobacco program was started in rural communities where there are typically less resources, less education, and more poverty. In rural communities, smoking tends to start at a younger age with higher smoking frequencies and a higher than normal smoking-derived mortality and morbidity rate versus non-rural areas. The Non-on-Tobacco program uses local facilitators that have been trained by the American Lung Association. By using local facilitators, the participants may see a social norm that does not include cigarette smoking. Every geographic location carries its own unique advantages and disadvantages, again, making the usage of local facilitators more of an asset on an individual basis. Equally distributing tobacco cessation programs helps to reduce or eliminate additional disparities and reduce marginalization. Communities with high levels of teen smoking usually have limited health care services, are populations of low socioeconomic class, have low levels of education and high levels of unemployment and or high levels of blue-collar or service industry workers. The Non-on-Tobacco program offers a smoking cessation program free of charge and attempts to make smoking obsolete, no longer part of the normal social scene. In addition, the classroom facilitator may be a familiar face of the students, demonstrating the interest in local community members pursuing activities without tobacco. The Non-on-Tobacco program was developed by the West Virginia University Centers for Public Health Research and Training, a Center for Disease Control and Prevention Supportive Research Center, in collaboration with the American Lung Association, the West Virginia State Health and Education Departments, and the Coalition for Tobacco-Free West Virginia. West Virginia University and the American Lung Association agreed that a teen cessation program should not simply be an adaptation of an adult cessation program, but include life skill components in addition to smoking cessation. The Non-on-Tobacco program was created for smokers ages 14 to 19, utilizing locally acquired facilitators trained by the American Lung Association. Local facilitators are typically teachers, counselors, and school nurses. Creation and implementation of the Non-on-Tobacco program was large in part due to the funding provided by the 1998 Master Settlement Agreement with the tobacco industry. Around 2005-2006, the funding from the settlement agreement for the most part dried up. At the program's height, it was found in 48 states. Today, the primary focus is in Colorado, Wisconsin, Michigan, West Virginia, Washington State, Virginia, and Vermont. Tobacco use is typically higher in communities of low socioeconomic status that have unequal access to health care and that have unequal access to power. Areas of poverty, along with education and housing inequality, have limited resources to smoking cessation programs. The program is almost entirely funded by state money. Due to lack of funding available in most school budgets, unless the program is provided by the American Lung Association, facilitator funding, copies, and all cessation program implementations, schools do not provide the Non-on-Tobacco program. When states cut budgets in smoking cessation, usually the first to go is funding for teen cessation programs. The Non-on-Tobacco program costs approximately $526 per school, including facilitator training, manuals and brochures, gifts, and incentives for the participants. Grants and subsequent funding is uncovered state by state through the American Lung Association and offered to school districts. Funding from states with a strong budget, such as Colorado, may offer facilitator incentives as a stipend, devices like Strauss balls and program pencils to teen participants, and free facilitator training. Copies, incentives, and presentation materials are never added to a school budget. However, facilitators may have to pay for training. Increasing funding can be aided by addressing or altering a community's societal norms. Addressing schools, parents, and communities on the benefits of smoking cessation has the potential to increase the public interest in the need of public funding. Ending teen smoking means teens having $702 per year more in their pocket by no longer spending money on tobacco, and potentially adds another 20 years to the lifespan of a previous smoker's life. Increasing advertising and awareness for the need and community benefits to a smoking cessation program may help to increase interest in funding teen smoking cessation programs. Changing social norms in an attempt to create contagious interest in smoking cessation needs to avoid concurrently creating stigmatization or marginalization of smokers. Implementing laws that create smoke-free public spaces while offering smoking cessation program aids in discouraging disparities between those who smoke and those who do not. Using social health determinants, looking at where people grow, work, play, and go to school, and limiting where tobacco is socially acceptable requires smokers to give up the tobacco habit. Otherwise, they are segregated from those who do not use tobacco. Government provides funding for public health endeavors through the Constitution, specifically through the purpose of promoting general welfare. The Non-on-Tobacco Program, which is directed by the American Lung Association and funded through government dollars, is provided to students while in school and attempts to bring in community members to create support for the teen smokers. The program not only is aimed at the teen smokers sitting in the classroom, but also includes community relationships and navigation of unhealthy societal stressors to increase the likelihood for smoking cessation. Balancing individual liberties and population health can collide, creating questions of whether smoking is the right of a person or a public nuisance and health risk. Public health programs work best when they address 3 levels of prevention: primary, secondary, and tertiary. How to prevent smoking-related injury or deaths at all, which would mean not only the smoker, but also those breathing in the carcinogen in the form of secondhand smoke. How to prevent or minimize the effects of smoking, and how to minimize the disability through medical treatment and intervention services. Opponents of teen smoking cessation programs include the tobacco industry, taxpayers, and smokers. When the 1998 Master Settlement Agreement, or MSA, was signed with the tobacco industry, which included approximately 40 tobacco companies plus Philip Morris USA, R.J. Reynolds, Brown & Williamson, and Lorillard, the settlement included annual payments that would be provided to 46 states plus 4 United States territories, the Commonwealth of Puerto Rico, and the District of Columbia. To this day, the tobacco industry has fought the settlement amount, which meant delaying the payments, placing the payments in escrow, going through the court system, and after being found in favor of the states, eventually paid each of the states and the United States territories. The MSA was not only meant substantial payments, but also the end of direct and indirect targeting of youths, no more brand name sponsorships, and lobbying restrictions, among other stipulations. For the general populations to see a public health need, they also need to accept the financial burden of responsibility. Smokers have encountered tobacco taxes that vary depending on the state and have been as high as $4.35 per pack. When a measure has been presented to voters, some states, such as California, have seen voters reject measures and increase taxes, which could not only be a smoking deterrent, but also means to pay for various government programs, including smoking cessation, health care, and cancer research. The Non-on-Tobacco Program focuses on smoking cessation when use, an area of public health that was neglected until the funding was provided by the 1998 Master Settlement Agreement with the tobacco industry. Unfortunately, funding is still an area of contention. Most finances have dried up from the 1998 settlement because, large in part, states use tobacco settlement funding to pay for other programs and budget shortfalls, leaving little to no money for smoking cessation programs. Teen programs are usually the first public health smoking program to be on the chopping block when there's a reduction of public health funds. About 3 out of 4 youth smokers will continue smoking into adulthood. Approximately 1/3 of all youth smokers will die of smoking-related disease. Roughly 2/3 of teen smokers state they want to quit smoking. Simply penalizing teen smokers by increasing cigarette tax does not alone encourage teens to stop smoking. Instead, the increased cost may create further income disparity. Having brief intervention moments in school, where students receive 5 to 10 minutes of instruction, some self-help brochures and minutes to answer questions, could provide an outcome of less years lived versus the Not-on-Tobacco program, where students are provided 10 50-minute sessions covering not only smoking, but healthy social habits that could discourage smoking. Disseminating a youth smoking cessation program that is adaptable to urban or rural can be used in school or extracurricular environments like 4-H cooperative youth programs, and accompanying legislative measures that discourage tobacco use help to make the Non-on-Tobacco program successful. An essential aspect of providing any public health program is informing, educating, and empowering people on public health subjects. Empowering should also be a key in financial planning. Political agendas are largely in part influenced by the demand from the community. Information provided during the Non-on-Tobacco program includes handouts for parents and encourages smoking cessation program participants to form solid relationships with their parents and family members, as well as to look to school staff as support system. Forged healthy relationships between teens and community members positively affect the entire community, therefore should be a community goal. The Not on Tobacco program covers making healthy choices, addresses drinking and drug use, exercise, and nutrition. The National Institute of Health, National Cancer Institute, classifies the NOT program as an evidence-based intervention and as a research-tested intervention program, or RTIP, and is listed in the Guide to Community Preventive Services. Money and resources allocated by community members and government bodies would be directed towards a proven program that helps teens pursue a healthy lifestyle. Why care if teens are living a healthy lifestyle? If trends continue, 5.6 million minors who are alive today will eventually die from smoking-related disease. The treatment and interventions required to care for smokers is a taxpayer expense. Unfortunately, if tobacco funds are allocated by state governments, teen cessation programs are usually underfunded or the first to go into budget shortfalls. The Center for Disease Control and Prevention calls teen smoking cessation programs essential, and that is an investment towards public health in all stages of life. Increasing advertising and awareness for the need and community benefits to a smoking cessation program may help to increase the interest in funding teen cessation programs. The Not on Tobacco program is a research-tested intervention program recommended by the National Institute of Health, National Cancer Institute, in helping teens to stop or reduce the amount of tobacco products being used. The NOT program has been large in part successful because of its adaptability and appeal to teens. To be a successful former smoker, the program developers and collaborators understood the goal should be greater than simply not smoking, but instead include evaluating reasons why the habit started, what to do to manage stress, and how to handle relapse. Traditionally, smoking cessation programs are focused in urban areas, leaving rural areas largely underserved. The irony is rural areas are home to teens who start smoking at a younger age than urban teens, could have circumstances where families work for some form of the tobacco industry, and have less resources available for medical care, introducing higher mortality and morbidity rates. In other words, rural areas are commonly devoid of funding for smoking cessation, even though they have minors that start smoking earlier than areas that traditionally are provided more funding. Teen smokers are 3 times more likely versus non-smokers to use alcohol and 8 times more likely to use marijuana. Addressing teen smoking can mean understanding and addressing causes for the teen to have started smoking and head off risky behaviors that could have even bigger impact on the health of the teens and the adults they become. Although it's early to say, the Not on Tobacco program is showing early signs in Colorado that it may help with discouraging and getting teenagers off of marijuana. States are increasingly legalizing marijuana, and this preliminary result demonstrates the NOT program's ability to adapt to changing concerns and risky behaviors changing with the times. There are 3 negative effects found about the Not on Tobacco program: financing the program and the effect on the tobacco industry, and ironically, the potential for an increased lifespan from the elimination of using tobacco products. There is not any shortage of literature on paying for smoking cessation programs for adults. However, programs geared towards minors is the first to be eliminated on a state government budget during a shortfall. Although data shows that today's teen smokers are a financial liability, leaving the community to pay for their ailments and early demise, government has taken more of the approach to put out the fire versus preventing it. As tobacco is villainized, the effects may be the additional loss of jobs for those that work for some of the form of growing, distributing, or selling tobacco. The decay of the tobacco industry should not be a reason for the elimination of the health buster. Instead, the societal costs should be figured and included in community smoking cessation models, much like what we have done with phasing out carbon emissions and dangerous environmental chemicals. A teen stops smoking and increases their lifespan by 20 years. Is there a financial burden to be borne by the community? If the individual lives to be 75 years old versus 55, of course there is medical care required depending on the stage of life. I question if a community makes more money from a healthy individual that lives to be 75 than a sick person that dies at age 55. Using a national syndicate like the American Lung Association and their connections has created a pipeline to schools to widely disseminate the teen smoking cessation Not on Tobacco program. West Virginia University Center for Public Health Research and their associated partners wanted to create a program that was not simply material removed from an adult program. Adaptability is a necessity, even to the point of recruiting community facilitators. The program is not to smoke The point is not to smoke or not to smoke. The point is what does smoking say about your lifestyle, your choices, where you can improve your health through nutrition education, or how about healthy relationships. When teens start making healthy decisions, the hope is they would phase out unhealthy decisions like smoking. Adapting the program from location to location is the simple part, so to speak, but if the school is large and you are still keeping classes small, less than 15 students, you may require more facilitators. So although the program itself is created and to be easily assimilated in a community, the number of facilitators may hinder program progress. In addition, not all areas are able to offer training facilitators free of charge. It depends on the funding that's available through the state. The school is never charged any fees. This means if funding is only covering the resources and supplies needed to produce the class, the facilitator may be required to pay for his or her training, affecting the ability for communities to locate facilitators.